Okay, I think everybody's in the room. So thank you all for joining our third GeroECHO session, which is going to be focusing on medication management of the cognitively impaired. I hope you all are doing well on this Friday afternoon / evening for some of you all. So thank you so much for joining today. We're gonna take you through our agenda. Again, our agenda is pretty much the same as it usually is. We're going to start off with our welcome announcements and introductions, and moving on into our didactic presentation, which is going to be led by Dr. Tatiana Gurevich, focusing on, again, on medication management. And then we're going to move on into our patient case and discussion, which is going to be led by Dr. Nguyen. Thank you so much for submitting a case for today's session, Dr. Nguyen. And then we're going to be moving on into our closing and reminders. Just another reminder is that this session and series is CME accredited. Our main objective is to educate community and rural healthcare providers in age-friendly geriatric patient care, treatment, and management, and to expand access to geriatric specialty care throughout California and beyond. This session is accredited for 1 CME credit. And if you do attend all of our sessions for this series, which is 5, you will receive 5 total CME credits. The California Board of Registered Nursing does recognize CME credits as transferable, so you will receive a health professional certificate, which you can submit to the CPRN as well. Quick reminders, please be sure to mute yourself if you're not speaking. Always try to introduce yourself prior to speaking with your name and location, and always be considerate of HIPAA and personal health information when speaking about the case presentation. This is a disclaimer that this session is being recorded, and they will be uploaded to a password protected database. So if you do ever miss any of our sessions, please feel free to reach out and we'll be able to share with you that password protected database so you can view the sessions later on. This is a program that is grant funded by the Health Resource Services Administration, and any information or content and conclusions are those of the author and should not be construed as the official position or policy from HRSA, HHS, or the US government. None of our faculty members have any financial disclosures at this time. And we're going to go ahead and move on into our introductions, as we always do at our session. So just a quick introduction of me. My name is Nika Seville, and I am a HRSA grant manager at UCI Division of Geriatric Medicine and Gerontology. And I also help coordinate our age-friendly GeroECHO series. So we can go ahead and move on to the rest of our hub members. Dr. Gibbs.
Hi, yes, I'm Dr. Gibbs, and welcome. I think everybody knows me. I'm the Chief of Geriatrics here, and I've had the pleasure of being on the prior 2 sessions, so thank you.
Thank you, Dr. Gibbs. Dr. Sagal.
Hi, everyone. I'm Sonia Sagal. I'm an internist and geriatrician in the Division of Geriatric Medicine, and I'm also the director of the fellowship program. Nice to see you today.
Thank you, Dr. Gurevich.
Hi, I'm Dr. Gurevich. I teach geriatric pharmacology at USC School of Pharmacy, and my practice site is at UCI Medical Center, where I've been since 2007, and I help out with these educational programs. And I'll be doing your talk.
Thank you, Dr. Gurevich. And Camille?
Hi, everybody. I'm Camille Fitzpatrick. I'm a geriatric nurse practitioner for UCI, and I work at the Family Health Center with our family medicine residents and nurse practitioner students. Welcome.
Thank you, Camille. And I believe we can move on into our spokes. Ann Ellett, please.
Hi, Ann Ellett. I'm a nurse practitioner in private practice, and I live here in Orange County, California.
Thank you, Ann. And Dr. Nguyen?
Hi, Connie Nguyen, family practice from Orange County, Kaiser. I'm a UCI resident, class of 2006, so so glad to have the opportunity to come back and be educated by my old faculty teachers again. Thank you.
Thank you, Dr. Nguyen. Dr. Rowe?
Hello, I'm Dr. Rowe, Jennifer Rowe. I'm the Associate Medical Director at UCI Emergency Department, and I'm the PI for the Geriatric Emergency Department Initiative.
Thank you so much. Dr. Hubi?
It's Dr. Hubi. I am family doctor in Calgary, Alberta, family medicine.
Thank you so much. I think we have a few others that are new. Let's see. Beatrice?
Hi, good afternoon, everyone. My name is Beatrice Vides. I'm a master's prepared nurse, and I work with the UCI Mind team on campus. And I will be entering postmaster's certification program to hopefully work someday as an adult geriatric nurse practitioner. So thank you for allowing me to be a part of this group.
Thank you for being here. And I think we have a few others on the phone. If you can go ahead and introduce yourself.
Hi everyone, my name is Tallene. I am a PGY1 pharmacy resident at USC. So today's actually my first day starting with this geriatric rotation. So thank you for having me.
Thank you for being here.
Hi, my name is Grace. I'm a fourth year pharmacy student from USC doing my API rotation with the geriatrics.
Hi, my name, go for it.
Hi, my name is Austin Stills. I'm also doing a fourth year rotation for geriatrics with Dr. Rich.
Thank you for being here.
Hi, my name is June. I'm also a fourth year student, pharmacy student at USC. I'm doing rotation with Dr. Gervich as well.
Thank you. Anyone else who hasn't introduced themselves yet?
I'm Shivali. I'm one of the geriatric fellows at UCI.
Thank you, Shivali. Anyone else? Okay, thank you all for being here today. We're going to go ahead and move on into our didactic presentation led by Dr. Gervich. So I will let her take it away.
Okay, thank you. So today we're going to talk about medication management in your cognitively impaired patient. Next slide. So we're going to talk about general medication usage in an older adult. We're going to discuss issues like polypharmacy and medication cascades, briefly review the Beers criteria, and talk a little bit about high-risk medications, and then go into our case presentation. Next slide. So this is just a fun slide because it sort of represents what was happening at the end of the 19th century and what's happening in the beginning of the 21st. And I don't think we've made much progress in between. Sir William Osler said one of the first duties of the physician is to educate the masses not to take medicine. And then 100 years later, a geriatrician out of San Francisco said there are many older adults who would be healthier if they threw away half of their medications. So unfortunately, we haven't made a whole lot of progress. Next slide. So this is a typical geriatric patient that we see at the Senior Health Center at UCI. They come in for geriatric assessment and a medication review as part of that. This slide is sort of out of focus, and I think it really speaks to how confusing it is for providers to manage complicated patients with multiple medications, but also for patients to take all this stuff on a daily basis. It's a huge quality of life issue, often, often a problem for older adults. Next slide. This is a patient we saw in a low-income housing project in LA. We were actually talking about nutrition with him, and he was complaining they didn't have enough money for food. And then we looked in his pantry, and this is what we saw in the pantry. 3 or 4 shelves full of herbal products that he was actually paying for in cash and using on a daily basis. When you look at his prescription meds, he's only on 4 medications, and it by some definitions, it wouldn't even qualify as polypharmacy, but if you look, there's a cascade going on with Wellbutrin being an activating antidepressant, which can often cause anxiety, agitation, insomnia in an older adult. And for that, presumably, he's given clonazepam, which is a long-acting benzo, so puts him at risk for falls, cognitive impairment, and obviously all the other herbs he's taking. There's lots of duplication, lots of unnecessary things that he's taking, and to go through that kind of a list, you really have to kind of look at everything carefully, figure out what's in each formulation, and start taking away a couple at a time, so that we can get buy-in from the patient to do that, because he obviously likes his herbs. Next slide. Over-the-counter medications are often not adequately discussed with older patients. 25% of patients don't tell their doctors about their over-the-counter use, and most physicians don't ask. And if you look at what's available, a lot of these products are high-risk meds, especially these like Tylenol PM, Advil PM, a bunch of first-generation antihistamines that can all cause cognitive decline. So we definitely want to ask about them, and ask repeatedly, because a lot of times it takes a few tries to actually get them to tell you what they're taking. On the bottom of the screen, you have things like Alka-Seltzer, which has about 1 gram of sodium in each pellet, and that obviously can cause other problems like edema, hypertension, things like that. Next slide. When you look at medication problems, in general, they're quite costly, and kind of cut across the spectrum of all kinds of healthcare settings, primary care offices, nursing homes, and hospitals. This graph shows a study out of England that looked at post-discharge medication adverse events. And we'd like to think that most of the problems are due to non-adherence, which I think comprises about 11% of the time. 3.4% is medication errors, but the bulk of the problem is adverse events from inappropriate medication use, and 13% are due to more than one medication being used at the same time, causing an adverse reaction. Next slide. So we've seen the slide before. Medications are now one of the pillars, so I'm really glad that we're focusing on this piece of it. And so, hopefully this problem will diminish or disappear. Next. So from my perspective, medications really impact each pillar. So what matters most, obviously with polypharmacy, there's a huge financial component to buying all these medicines, and so people on fixed income, that can really impact quality of life. The virtue of having to take all these medications on a daily basis can really also impact quality of life and adverse outcomes, so we really need to be cognizant of that. With the age-friendly health systems push, there's a really significant push to reduce high-risk meds, primarily those on the Beers criteria, and there's a push to deprescribe and really clean up the medication regimen. Obviously, things like depression, anxiety, agitation are very common in older patients, and so we want to manage them effectively with appropriate doses of antidepressants and monitoring for side effects. And a lot of cognitive decline and depressive symptoms themselves could be from the wrong medications being prescribed in the first place. So reviewing the med list has to be done. And then in terms of mobility, muscle pain and fatigue could be a medication side effect, like with a high dose statin or maybe a beta blocker. Dizziness could be a drug side effect, and fall risk could be increased as a result of improper medications being used. Next slide. So why do these things happen? I just want to briefly go over some of the PK changes that happen with aging. The biggest one is the renal insufficiency one. Here's a creatinine clearance equation that we still use in our practice. I want to remind people, if they are going to use it, use either adjusted body weight or ideal body weight. You don't want to use total, because that'll overestimate kidney function. The primary reason is creatinine is a muscle byproduct, and most of the weight in an older adult is due to fat. And these are kind of the three benchmarks that I look at. If the creatinine clearance is greater than 50, you really don't have to make any medication adjustment dosing. 30 to 50, you do have to maybe adjust a dose. and that's where clinical judgment comes in. And then less than 30, a lot of the meds should not be used or can be used at significantly reduced doses. The other thing to point out is because there's an increase in body fat as we age, half-life tends to increase with all the lipophilic medications, anything that has to enter the brain, benzos, opioids, some of the other psychotropics tend to have extended half-lives, and more adverse events can happen in an older adult as a result. So that's one of the reasons we reduce doses. Next slide. So the basic motto in geriatrics dosing is start low, go slow, but do go. So we typically start with half the recommended dosing. Titrations are slower, but you do want to get to a therapeutic point. So sometimes maximum doses are necessary, and usually that's guided by tolerability. So you usually stop when you encounter side effects. Next slide. So what is polypharmacy? There's lots of different definitions, and there's really no consensus. In my opinion, it's an irrational list of meds that's actually independent of the number of medication being taken. So the slide we saw previously where a patient was only taking 4 medications, it's a small number, but within that short list, there's obviously a cascade going on that could be prevented. So I think all geriatric patients are at risk for polypharmacy. And if you see a med list of 5, that puts the patient at risk for polypharmacy. So that medication list has to be reviewed carefully. Next slide. Any symptom in an elderly patient should be considered a drug side effect until proven otherwise. That's really the approach to take when you're trying to limit polypharmacy kinds of issues. When you look at this wheel of symptoms, memory loss, depression, dizziness, incontinence, insomnia, all of these could be new onset medical problems, but they could also be drug side effects. So the easiest thing to do is kind of look back and see what recently was prescribed and see if you can tweak it, decrease the dose, or maybe even discontinue an offending medication before you go down the path of diagnosis and workup and maybe treatment with additional meds. Next slide. So here's an example of a prescribing cascade. This is the most common reason why you have polypharmacy, because people don't pay attention to what was prescribed recently and things like that. But this is a gabapentin causing edema. We see it in our clinic very often. And so patients can start on gabapentin for chronic pain, come back with swollen ankles, and then they get started on a diuretic. Obviously, that can lead to hypotension, potentially incontinence, an electrolyte imbalance. You're putting the patient at risk for falling, huge quality of life issues, especially if incontinence is involved, or falling, and obviously a more complicated regimen. So when you do see edema that's caused by gabapentin, one thing you could do is back off on the dose. That's one of the reasons when we use gabapentin, we start with 100 milligrams at bedtime and titrate up very slowly, or discontinue the drug if it's causing the side effect at that low dose. Next slide. So the Beers criteria has been in existence since the 1990s, and initially it was targeting the skilled nursing facilities where there was a lot of medication mismanagement going on, but now it's really appropriate to apply it to any healthcare setting, including ambulatory care and hospitals. The medication list covered on the Beers list span all the meds that cause cognitive decline, and that's what we're going to focus on today, but also cut across, cardiovascular medications for endocrine disorders and such. So it's really a good idea to review the Beers list. It comes out every couple of years, and there are always significant changes made. So really what the target of the Beers list is to alert providers about the potential for adverse outcomes while they're using certain drugs, and kind of monitor patients carefully if these medications are necessary. Next slide. So this is sort of the bread and butter of the Beers list. I want to spend a little bit of time going over this. These are all drugs with anticholinergic properties. And on first glance, you think, oh, I know all of them. But look at it carefully. So antidepressants, we know all tricyclics are anticholinergic, and we know amitriptyline is the worst offender. But things like desipramine and nortriptyline, which are low anticholinergic profile, are still on this list. Paroxetine, which is a +1 compared to a +4 amitriptyline in terms of anticholinergic activity, is also on this list. all urinary antispasmodics. We know oxybutynin oral tablet is not tolerated well, but trospium is supposed to be a safer option, and it's still on this list. All the first generation antihistamines that are over the counter are on this list. Hydroxyzine, which is still prescription, is on it. GI antispasmodics used for irritable bowel with a predominant symptom of diarrhea are on it. So and things like promethazine, which is Phenergan, which we use for upper respiratory infections. So go through this carefully, and if you have a patient with cognitive decline or you're suspecting some kind of a memory impairment, go through the medication list and make sure that none of the meds are on it, because they can definitely be contributing to this problem. The other issue is the concept of anticholinergic load, which is when you have more than one medication with low anticholinergic profile altogether, it can really add up and cause significant clinical change. Next slide. So the next several slides are really discuss the drugs that are on the Beers list. I'm going to go through it relatively quickly, and I really encourage you to go back and look at it a little bit more carefully. So the highlighted sections are the ones that are are significant for cognitive impairment. So benzos, non-benzo hypnotics, antipsychotic agents. We actually use them at the Senior Health Center quite a bit, especially in patients who are having severe agitation that's not managed by non-pharmacologic approaches, and this is kind of the last option for treatment. They do increase the risk of stroke and increase the risk of mortality, but sometimes it's risk versus benefit, and the benefits outweigh the potential risks. You want to avoid antipsychotics in Lewy body dementia because sometimes they're poorly tolerated in this patient population, I think because there's a dopamine component to the disease process, and these drugs are anti-dopaminergic. Next slide. So these are the same drugs that cause falls and syncope. So a lot of the anti-benzos, non-benzo hypnotics, SNRIs and SSRIs, and mirtazapine, we use like water in our clinic. And the trick is to use them at lower doses, titrating slowly, and monitor patients for dizziness. Cholinesterase inhibitors, those are the things that we use for dementia, are on the Beers list for the reason that they can cause falls and syncopal episodes. So again, slow titration and careful monitoring is important. And then for delirium and cognitive impairment, we've already talked about this, anticholinergics, again, sedative hypnotics, and some other medications. Next slide. So again, so all the antidepressants and novel antipsychotics are there for the risk of hyponatremia, so check your electrolytes. Nuedexta should only be used in patients with pseudobulbar affect and not for generalized symptoms of agitation. Some things are removed from the Beers list, and in this recent iteration from 2019, they removed oral decongestants because the insomnia that you commonly see is not limited to just geriatric patients, but it can be seen in all age groups. But the thing is, oral decongestants can cause more severe symptoms in older patients. So not only insomnia, but also agitation, severe anxiety, and sometimes increase in blood pressure as well. H2 blockers were removed from the Beers list because it was felt that, we don't want people to be on PPIs, so what's the alternative? H2 blockers. So they're actually safer. And H blockers, the evidence for them causing cognitive impairment is fairly weak, primarily seen with cimetidine, which we don't use very much anymore. And so the only time you don't want to use H2 blockers is when when the patient is acutely delirious. But if it's chronic dementia and you need an acid blocker, H2 blockers are a reasonable alternative to PPIs. Next slide. So again, some useful drug interactions. This has nothing to do with cognitive impairment, this top one, but we see it a lot. Somebody's on an ACE inhibitor or an ARB with a potassium-sparing diuretic and they're fine. You add something like Bactrim and there's your hyperkalemia. But in terms of cognitive decline, again, watch the number of anticholinergics on the list, limit them or eliminate them altogether. Next slide. Some dosing adjustments on the Beers list. So again, some of the commonly used antibiotics and some things like duloxetine, tramadol, and gabapentinoids, which all have to be renally adjusted. And these benchmarks are similar to the ones that we talked about in previous slides for creatinine clearance. Next slide. So when I'm looking at a patient with a potential diagnosis of dementia, what I do is obviously go through the meds, and you really want to eliminate medications as the cause for it. So again, anything centrally acting, look at the doses and the need for them and eliminate what you can. Sometimes beta blockers can make patients tired and slow down, and sometimes they don't test as well on neurocognitive testing. So reevaluate the use of beta blockers and only use if there's significant benefit. Same thing for something like a clonidine, which is a centrally acting alpha agonist. Sometimes inhalers and eye drops will cause systemic reactions in older patients. So like if you're using a beta blocker eye drop for glaucoma, that can cause similar symptoms as oral beta blockers. Inhalers like, things like albuterol and nebulizer, especially via nebulizer, they can cause agitation, insomnia, agitation in an older adult. Review your over-the-counter medicines and herbal medications for hidden ingredients. That's really important when you're looking at a demented patient. And ask about marijuana. A lot of times we ask about drug use. Nowadays, people don't consider marijuana a drug. So ask about that, because we still don't know what the impact of cannabis is on a demented brain. Next. So let's talk a little bit about the drugs we have to treat dementia specifically. So first are obviously cholinesterase inhibitors. The ones we usually use will be donepezil or rivastigmine. We generally don't use galantamine because I don't think it offers anything additional to the mix. Donepezil, long half-life, 70 hours, so it can be used once a day, and the dose is usually 5 to 10 milligrams. Using the 23 milligram tablet is really not, doesn't add anything other than more side effects. So you usually start 5, wait about a month, and if it's well tolerated, go up to 10. Rivastigmine is also an option. It was initially developed as an oral agent, and it was so poorly tolerated in terms of cholinergic types of side effects that they had to invent a patch. So if you're going to use rivastigmine, I would recommend using a patch. Much shorter half-life, that's really the only difference, but in patch form, it really doesn't matter. Next slide. So side effects of cholinesterase inhibitors are pretty common, and if you ask about them, you'll notice patients actually have them. So nausea is very common, diarrhea, vomiting, anorexia, and weight loss could be really significant in an older patient. Bradycardia, you often watch the pulse with these drugs, especially if they're on other medications that can further cause bradycardia, like beta blockers or certain calcium channel blockers, for example. Dizziness and syncope are the reason they're on these drugs are on the Beers criteria. They can cause vivid dreams and somnolence, and we always give it to them at night to avoid syncopal episodes and decrease the risk of falling, but they will report vivid dreams. Incontinence or frequency in urination, which can lead to incontinence, is a huge lifestyle stopper. So sometimes that requires us to either discontinue the donepezil, switch to memantine, or reduce the dose. Drooling, runny nose, watery eyes, not a huge problem in terms of the side effect, but what that often does is sends the patient back to the pharmacy to buy some antihistamines, and they will often buy first generation things that work very well for these symptoms. And that obviously directly counteracts the effects of cholinesterase inhibitors, and the way they work is increase acetylcholine levels as opposed to antihistamines being anticholinergic. Next slide. So some practical issues. The thing you have to realize is that the benefit of these medications is relatively small. So you really have to set reasonable expectations for family. So what I usually tell them, if we start cholinesterase inhibitors and we see no change or no decline, that means that the drug is working. I think the effect on cognition is very mild. There may be some mild improvements in independence or self-care, but it's really quite limited. And typically the stabilization lasts for about a year. So how long do you take this medicine? I think as long as the patients are stable, I think it's reasonable to continue. When you start seeing a decline, that may be a time to think about discontinuing discontinuing the medication because it's sort of outlived its usefulness. Sometimes when patients are stable and they don't see a change, they think the drug's not working. And that's the time when you do some counseling and explain the benefits of it. Because when you do stop it, when the patient is stable, sometimes you do see a sharp decline. At least you see that anecdotally. Next slide. Memantine has a different mechanism of action. It's neuroprotective. And again, it's usually used in more advanced cases of Alzheimer's disease, so moderate to severe, usually in addition to cholinesterase inhibitors. And in terms of cognitive improvement, there's maybe a slightly increased score on the MMSE, but it really translates to very mild improvement. So it's usually used as an add-on to cholinesterase inhibitors in more severe cases, or if cholinesterase inhibitors are not tolerated. Next. In terms of memantine, it is renally excreted, so you have to adjust for renal insufficiency in your severely impaired patients. And dosing is usually either BID for your regular release medication, so start with 5 a day and go up to 10 twice a day over about a month's time, or you can do extended release formulations, which are easier for, just once a day extended release. Capsules are also available. Memantine is generally better tolerated than cholinesterase inhibitors. Side effects are seen only about 5% of the time. Agitation is very minimal. Things like diarrhea and insomnia are much less likely to happen with memantine than with cholinesterase inhibitors. Some dizziness is reported, some hallucinations, but overall, this medication is better tolerated than cholinesterase inhibitors. Next. So again, you could start it with mild to moderate symptoms, probably closer to moderate, typically used in conjunction with acetylcholinesterase, evaluate for adverse drug reactions in the first month of treatment, and overall effectiveness about every 6 months. Next. So basic principles are start with lower doses, titrate up slowly, but do get to a therapeutic dose. Simplify drug regimens. The fewer meds your patients are on, the healthier they're going to be, and the more able they are going to be at complying with the regimen you're prescribing. And use the Beers list as a guide. Try look for things that are on it, understand why those drugs are on it, and kind of monitor progress carefully. That's it. Thank you. You're muted.
Thank you so much, Dr. Gurevich. That was a great didactic presentation. We have a few minutes available for questions for Dr. Gurevich. Does anybody have any questions? Go ahead, Beatrice.
Thank you, Dr. Wersch. I have a question. So we see a lot of participants or patients that have been diagnosed with mild cognitive impairment, so not yet demented, and they often ask us if they should begin treatment with cholinesterase inhibitors. And I just wanted to get your take on whether or not that's standard of practice, or what can be said to these patients who are seeking treatment but not yet demented.
So officially, so mild cognitive impairment does not necessarily qualify a patient for a cholinesterase inhibitor. I think the best thing to do in that case is to review the med list, make sure nothing is contributing to the decline, and kind of watch the patient. Some patients want to start the medicine, and so I think that's a decision you make on an individual basis. But the indication for cholinesterase inhibitors would be mild dementia. Sometimes when these things are started earlier, the progression is slowed down, so it's reasonable to start it earlier. So I think it just depends patient to patient. Does that answer your question?
Well, I guess also, Dr. Gurevich, they're not FDA approved.
They're not
for MCI. So
they're not.
So if we're going to be technical about it, it's not FDA approved for that. Now, do we see people using them? Not so much Well, I think the answer is yes, we do see people using them. We see neurologists using them earlier than approved for. But also I think other people do use them because there's really nothing else in our arsenal to use. So I think I agree with Dr. Gurvich, it's kind of like a patient preference issue as well. You know, do we have somebody who doesn't mind taking medicines? Do they want to try this at all costs? Do they want to, you know, understanding that the benefit is low, do they want to just potentially wait until, you know, MCI turns into potentially a mild dementia where we have more evidence base? So those are difficult questions, but I think that the answer is they are used because I think more so because we have not much choice.
I think it also depends. I think it'll, like, if somebody's already like, side effects of cholinesterase inhibitors are significant, so you really do want to look at individual patients. You know, incontinence is a huge problem for older patients. Diarrhea, urinary frequency, those could be potentially life-altering kinds of side effects, and cholinesterase inhibitors do cause them for really minimal efficacy. So that's the discussion, I think, to have with them.
Okay, thank you so much. I appreciate your response.
Thank you. Go ahead if we have one more question, and then we'll move on into our case.
Well, thank you. I was just going to say that, yes, these medications, as you shared, are not without risk and adverse effects. And someone with MCI, would you consider just talking about lifestyle changes such as alcohol and exercise and dietary and things that that perhaps just can also help stabilize them before considering prescribing a medication, which is really off-label for this?
Absolutely. We always ask about alcohol, and I'm always actually surprised at how often it's being used on a daily basis and how much. Sometimes cannabis is used quite frequently, and I've seen patients on fairly large doses of THC. So all of that needs to be kind of cleaned up before you consider medications to treat the symptoms. And then sometimes when they're depressed, you know, treating the depression or anxiety can sometimes improve symptoms of memory loss. So all those underlying things have to be fixed before.
Right, and we do put a lot of emphasis on diet, exercise, and social stimulus. Just keeping the mind active. But yes. Great comment. Yeah, the topic is pharmacology, so we kind of glossed over that, but absolutely we do non-pharmacologic interventions first.
Okay, thank you.
Okay, thank you so much. If anybody has any other questions for Dr. Gurvich, you could definitely type it in the chat, or we can try to answer them at the end of the session. But we're going to go ahead and move on into our case-based presentation. And thank you again, Dr. Gurvich, for your presentation. And we'll move on to Dr. Nguyen, who will be presenting the case for today. Dr. Nguyen, you can go ahead and summarize this case. Can everybody see the screen with the case up? Okay, great. Go ahead, Dr. Nguyen.
All right, thank you. Thank you for giving me the opportunity to present one of my patients today. The reason I picked this patient is I would like to get your guidance, your recommendation on two specific issues. One of them is medication management, as the talk today. Particularly pain management for her chronic pain. The second issue is how to improve her functional mobility. So this patient is an 88-year-old female who has been my patient for the past 10 to 15 years. Her past medical history include history of atrial fib, hypertension, history of lacunar stroke, diastolic heart failure. She has a history of PAD, peripheral edema. She's also started post bilateral hip replacement surgery. The left one is in 2007, I believe, and then the right one is was in 2018. She also has significant chronic low back pain, secondary to DJD and spinal stenosis. She also has moderately severe osteoarthritis in her knees and her shoulders. She is obese, BMI at 36, at her last visit with me last month. Now, I knew last month when I saw her that I would like to present her case, so I updated her mini mental status and her get up and go test, as you can see on my submission form there, mini mental status 24 hour 30. Now her get up and go test was not great. It was 25 seconds with a walker. As I have noticed over the past few years, her mobility has steadily declined. I remember just a few years ago, she was able to come in on her walker to see me. But I would say in the past year to 2 years, she pretty much come in on the wheelchair with her helper pushing her. List of medication, as listed on my submission form there, you can see she's on Lasix, she's on atenolol, she's on a statin, she's on amlodipine, she's on Zetia, she's on Fosamax, Pepcid, she's also on Pepcid, and she's on aspirin. Now, specifically for her pain management, currently she's only on topical generic Voltaren twice a day and over-the-counter Tylenol as needed for pain. In the past, we have tried to manage her chronic pain a little bit better with opiates, but as you can see from her medication list, that she did not tolerate opiates really well. We try everything from codeine to hydrocodone, even Dilaudid and morphine, and the patient had significant nausea and vomiting. She also reported that opiate make her felt really loopy, so we did not want to go further with that. In terms of her decline mobility, I think certainly she had a lot of comorbidity, but I think a significant part of it is her chronic pain, from her back pain to her hip pain, her knee and her shoulders. And it's been difficult to manage her chronic pain. And I think that's certainly contributing to her decrease in function. So that's my patient. She's a wonderful lady, always happy, very reasonable. As you can see on my form when asked about quality of life, what's the focus of care for her? That's what she said is, she said, I want to focus on quality, but it would be nice to be able to get around more and not to be in so much pain all the time. So I told her that today I'm going to present her case to a group of geriatric experts who are a lot smarter than me, and hopefully you can give me some recommendation that can improve her care. She's such a wonderful, and I wish I can provide a better care, especially managing her pain better. Thank you.
Thank you so much, Dr. Nguyen. Does any of our folks or team members have any comments or questions for Dr. Nguyen? And if not, then our hub team can go ahead and ask their questions or start providing recommendations. But this is definitely a team-based discussion. So if anybody has anything to add, please go ahead.
So I have a question. Why is she only using Voltaren gel twice a day?
That's the typical dosing that we write here at KP, Voltaren twice a day, topical.
Because it can be used 4 times daily.
I see.
Yeah. And I also, it's kind of funny, but it comes with a little measuring stick. Oftentimes it gets stuck on the top of the package and the patients don't even realize they have it. But to get 2 grams, you need 1.25 inches. for every dose, and that's a pretty significant amount if you look at it when you measure it. So I would make sure that she's using an adequate dose every time. And for lower extremities, you can use actually 4% Voltaren gel. I don't know if that's on the formulary at Kaiser, but that would be 4 grams. Sorry, so that would be 2.5 2.5 inches. So I would make sure she's using Voltaren adequately. The other thing, Tylenol, you can use up to 3 grams daily. I'd put it on a regular schedule as opposed to PRN.
So the 4 gram is a total dose
so it's
per application?
Yes. For lower extremities, it's 4 grams 4 times a day. For upper extremities, it's 2 grams 4 times a day. I would,
because I know I know she applied to her shoulder, her back, her knees. Those are the 3 areas. Yeah.
So I would do it more often.
Okay.
Because it can be effective, and make sure she's measuring it out. Right.
Okay.
Have you tried oral NSAIDs on her?
We have. Looking at the list of medication in the past, I noticed we try Naproxen, Meloxicam, I think Motrin, 600 milligram. We've done that in the past. I think because of the concern for GI upset, because she does have some history of gastritis. That's why she's on the Pepcid, and she also on aspirin. We decided to avoid oral NSAID and switch her to topical NSAID. Yeah.
Okay. And then gabapentin?
Yes, also looking at the history of her medication, she was on nortriptyline in the past, along with gabapentin in the past. I think the reason why we discontinued was because she didn't feel like it was as helpful. I know her back pain intermittently would have radiation to the distal lower extremity. So I think that was one of the reasons for nortriptyline and gabapentin, but I think we discontinued because he didn't feel like it was helpful for her.
Okay. I mean, the other option is topical lidocaine.
Oh, okay.
For the back, 4% is over the counter, 5% is prescription. You can, I mean, I wouldn't lather it on all areas, but the lower back area, that might be helpful topically.
Very good. I don't think I saw that on her old list of medications. So lidocaine would be one. Okay.
So sometimes all these things individually kind of take a little edge off, but together it could provide enough pain relief that make an impact. So even if gabapentin doesn't completely take away the pain, if it takes the edge off, maybe that will improve mobility slightly. So I'd have to look at how it was used. Maybe you could email me with the actual regimens that she was on, but maybe we could do something.
Yeah, in your talk, you also mentioned beta blocker and statin causing issue with gait. Is that correct?
No, so statins cause muscle pain.
Okay.
And so just sort of generalized muscle pain, usually in the legs, but we kind of see it everywhere. So sometimes switching to less lipophilic statins like rosuvastatin or pravastatin can be helpful. You know, with her medical history, I wouldn't take her off a statin necessarily. That might change something. I mean, change a statin. The other thing, beta blockers just make you tired.
I see. Okay.
Kind of depressed looking and slow. But she's got AFib, right?
She has AFib, yes. Yeah. Yeah, because I know beside the joint pain, she does mention muscle pain also.
Yeah, it could be a statin. I would, and sometimes those two in particular will work a little bit better. And with rosuvastatin, that's a more potent statin, so you might be able to use a lower dose. And a lot of these things are dose related. So, she could be controlled on 10 milligrams of rosuvastatin, which causes less muscle effect.
Great. Definitely would consider that, yeah.
So this is
Hi.
Camille. I have a question, a couple of questions.
Mhm.
How is this really affecting her functioning? Is she in pain all the time, so she just doesn't move at all? Does she not sleep? Can you explain a little bit more kind of about her pain?
Yeah, I would say more activity related. When she described what she does at home, she said just getting up and go to the bathroom, getting up to go to the kitchen to make something, it would be painful. So it tend to make her more sedentary because it just hurts to move. So that's how she would describe it.
Right.
Yeah.
So she doesn't move, which makes the pain maybe, makes her have more pain. And I just wonder, has she tried any kind of water activity, not necessarily water aerobics, but at least getting into the water, a pool and moving around?
I don't think she has. I know we tried physical therapy with her about 2 years ago, about 2018. She did go through a couple sessions of physical therapy, but aquatic exercise, no, we haven't tried that.
Yeah. I just, on a personal note, I go and there is this really elderly woman that can hardly move. She has to have somebody get her in the pool. And she is moving and she is coming and feeling better. So sometimes water just takes the pressure off and gives her a little bit more of a sense of being able to move and have a little bit less pain.
Yeah, I agree with you. I think it's going to improve her function and her pain level.
Okay.
Thank you.
Hi, this is Jennifer Rowe from UCI Emergency. I actually have a question for the pharmacists. If a older patient is in significant pain but does not tolerate opiates like this patient, have you ever tried or recommended, or the geriatricians, have you ever recommended Suboxone or buprenorphine? Is that an alternative? Has that shown any evidence of improving? Just because in the ED we are able to prescribe it. I don't think we're super comfortable giving it to older patients, but we've had such success with other patients. So I was just wondering.
We haven't recommended it at the senior health center. We have a few patients with opioid use disorder that are on it, that where it's being prescribed on the outside. We generally don't use it.
Dr. Gibbs at all? Just because I think the evidence with Suboxone and buprenorphine, there is a pain treatment component to it.
Well, that's a great question, and I have actually never considered it. I think it's something that we can do some research into and see if it's a really plausible option for our patients. This is a great example of learning from across disciplines.
Yeah, because we're actually getting a lot. You require an X waiver to prescribe it for long periods of time. But we're using it more and more in the emergency department because we're allowed to order it in the ED even if you don't have an X waiver. But I believe myself and Dr. Chakravarthi, I was the first X waiver because I did it in fellowship. But we have now, I think we've licensed a good number of our faculty. So yeah, it's actually, I guess it is a little cutting edge. But yeah, if we could, I don't know, if we could look into it for older patients, I think that'd be an interesting potential alternative.
Dr. Gurvich, would you maybe be able to look up and see what the evidence is with Suboxone in older adults?
Absolutely. Well, the students and I will look into it and we'll get back to you early next week.
Awesome. Thank you.
Yeah, we'll disseminate to the group so we can all learn.
So the other question I had, have you ever tried maybe duloxetine? Is this patient, is there a mood component to her feeling pain? And sometimes that can be helpful.
Yeah, I think that's actually a great idea. Looking at her list yesterday, I did not see that either, that we have tried that in the past.
So I would start really slowly, like with 20 or 30 milligrams daily.
Okay.
And just keep an eye on, because, you know, one of the things you're looking for, extra dizziness. So I would give it at night. You know, if she gets up in the middle of the night, make sure she holds on to something and just titrate super slowly. And then at higher doses, you can see sodium drop. But usually,
I see.
so just keep, but it doesn't usually prohibit you from using it necessarily. You can get to a pretty high dose without any sodium issues.
How slowly do I need to go? Like every 3 to 4 weeks? I can titrate it or longer?
So no, you know, you could do, if you start with 20, you could probably wait a couple of weeks and kind of reassess. But certainly within a month, you can go up. You go up to 30 or 40, kind of double the dose. Yeah, and then and then titrate up to effect.
Okay, sound great.
Hi, hello, this is Dr. BD. I'm from geriatrics. I have a question for you. I know that what I heard is that pain is driving the decrease in mobility. Have you ever tried non-pharmacologic measures such as a nerve block or even acupuncture? I heard physical therapy, but I didn't hear many of the other available treatments.
So I don't believe we have tried acupuncture before. I know for her shoulder and her knee, I have tried cortisone injection in the past. For her back pain, our physical medicine department here has tried epidural injection in the past. I think her last cortisone injection was in 2018, and her epidural injection was about 2016 and 2017, but no acupuncture. I think that's certainly we can consider.
So the other thing with interdisciplinary stuff, occupational therapy is really good at kind of redesigning your daily routine to kind of accommodate more painful times and, you know, help them deal with flare-ups and things. So I work with, at USC, I work with a couple of really good occupational therapists who actually do pain management. I don't know if Kaiser offers that, but that's a thought too.
Like a home assessment from occupational? Okay.
Yeah.
All right. Great. These are great ideas. Thank you so much.
Thank you. Well, we're coming up on time. Does anybody have any last minute comments for Dr. Nguyen?
Well, I commend Dr. Nguyen. I can't believe it's been that long since he graduated.
Coming up 15 years, I think.
You have to be kidding me. I just can't even believe it. But anyway, I would just commend you on your care, and great to see you.
Thank you. Appreciate it.
Thank you all so much for attending today's session. Just some quick close out. Our next session is on October 23rd, and it's going to be focusing on mobility. Dr. Biddy is going to be our presenter, and we are looking for cases. So if you do have a case to submit, please go ahead and do that. I'll be sending a follow-up email to everybody, all of our attendees, with our fillable case template and also more information about our future sessions coming up. So be on the lookout for that email. You will also be receiving an evaluation link. Please go ahead and fill out that evaluation for today's session. It really helps us in deciding on our future topics for our next series that we're hoping to start in the new year, and also evaluation for our presenters as well. So please be sure to fill that out as soon as you can. And we look forward to seeing you all on October 23rd. And again, that session is from 12 to 1 Pacific Standard Time. Again, the same login info for all of our meetings. Does anybody have any last minute questions or comments before we end today's session? Okay, again, I want to thank Dr. Gurvich and Dr. Nguyen for leading today's session, and we all hope to see you all on the 23rd.
Thank you. Bye-bye.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Huh.